as we were talking about before, I'm interested in how telemedicine works in your hospital, at Mercy, in your system. What is the biggest impact that you can think of? Can you talk about that a little bit?
Yeah, absolutely. So telemedicine, we refer to it as virtual care in our organization, but it's fairly pervasive throughout Mercy. It's evolved over the last 6 or 7 years from a few physicians wanting to experiment to a very intense part of our overall response to every community. We focus a lot on access to health care at Mercy, and when you have many hospitals in rural communities, perhaps the best way that you can bring subspecialty care to their community is through telemedicine. And what's fascinating to me when we visit those communities and host community roundtables with local civic and business leaders and talk about what's important for healthcare in your community, and we begin to describe the concept that healthcare can be simultaneously local, regional, and virtual, they're fascinated by the thought, and it's a quick leap for them to embrace the idea that the best way they can bring some of that care to their community is virtually.
So this has an effect on each of your hospitals. Can you describe your communities?
Sure. So it absolutely has an effect on our hospitals, but Mercy's more than a hospital company. Maybe the best way I could illustrate that, we take care of about 3 million people on an annual basis, and only 150,000 of them spend the night in our hospital. All of the rest of them are cared for in some ambulatory setting. So a lot of times we will talk about telemedicine, though, in the context of the electronic ICU, or we call it SafeWatch, where all 400 ICU beds at Mercy are monitored from a command center in St. Louis with intensivist physicians and ICU-trained nurses. It had a really profound effect. Mortality is down 20% below the expected rates in our ICUs, and the length of stay is down 30%.
So that's made a real difference.
It has. So it's helped clinically. People have got to go home that otherwise wouldn't have. And the economic burden of healthcare in that community has been reduced. I mean, when people get out of the ICU quicker, the bill we send out is less. So therefore, the economic impact is less. But that's just one side of it. We do telepsychiatry. We have physicians that are experts in childhood development issues and are able today to diagnose autism remotely using telemedicine capabilities. And every other kind of service, ENT and other things that are all possible today. So we just keep expanding the sphere of specialties that can use telemedicine to deliver care.
And you also have a telestroke program? We
do. Telestroke was a really critical thing because there's such a shortage of neurostroke specialists. And patients come to the emergency room with a stroke, and if it's a stroke caused by a clot, then TPA administered can reverse the effects. It's just fascinating to watch these people come in and they may be unable to move on one side of the body, they can't speak, and within 12 to 15 hours after TPA, they look like they're recovered. The sad thing is it only gets administered about 10% of the time when it really could, because the ER physicians need that help of that neurostroke specialist to make sure they get the right diagnosis, because just as curative as it is, if they pick the wrong patient, it can be deadly as well. So they're very cautious about it. So we use telemedicine to bring the neurostroke specialist service to every community where we have a hospital. And the first community that we took the service to, they administered more TPA in the first 6 weeks than they did in the entire previous year. So think of the lives in that community that have been impacted. No debilitation from stroke, or much less debilitation for sure.
So there are big, I was going to say there are big things going on, but there are big results from your use of what I'll call telemedicine.
There are
virtual care.
Lives are impacted by it, and communities are also impacted because of better healthcare economics.
When did you start at Mercy? I know you've been there for some time, so you probably were there at the beginning. When did you see it taking hold?
Yeah, it was probably 2006 or so when we really made a big investment in the virtual ICU. And it was a ministry-oriented decision. It wasn't a business decision. We knew we could.
It was your mission.
It was our mission, and we believed we could impact the health and the lives of the sickest of the sick patients that we have. And it just continued to prove itself. And as our physicians gained confidence in that model, they began to expand it to other areas. And today my job is trying to stay a step ahead of them and find the funding to really get it all done.
Is it hard to find the funding?
Well, I think there's always competing demands for capital,
Yes.
and all good ideas, and you can't do them all. But the number that are telemedicine oriented are growing all the time. And we've actually committed to a strategy to create a virtual care center where we really aggregate all these services together. And it's strange to think of a physical building and virtual care, but you need a hub to organize things. And it doesn't mean that all the care will get delivered from that facility
In a
to
physical
another
place,
place,
yeah.
but it will be sort of like the switchboard operator to keep all these things working.
So that's in the works.
It is. It's going through the final stages, and we hope to break ground maybe this fall.
Okay. I wanted to talk to you a little bit about your background in supply chain management, because I read that your start at Mercy was in that field or in that focus. Has that influenced you in any way, or how does it connect to what you do today?
I think a number of ways, but maybe the primary one, in that world in supply chain, I always view technology as a key tactical enabler of getting things done. And I view it that way in the clinical world now, too. It is through the use of technology that we extend the mission of Mercy and bring access to care and bring a higher level of care, a higher standard of care to every community. I mean, you can be in an urban setting, St. Louis, and expect a certain standard of care, but in a small rural community, it's hard to receive that or even expect it. But the sisters have always taught us that only the best for those that we serve. And so if we're going to do that and honor their commitment around it, we're going to have to be innovative, and technology, I think, is the way we do it. And so I think that's how my supply chain background helped me think about the delivery of medicine in a different context.
Because you already had that technology piece in mind.
I was used to
Yeah.
technology
Yeah.
being that enabler, and it shouldn't be a roadblock. And it just took an experience of physicians, a cultural transformation in their mindset about that it could be good medicine.
What's the big message in your keynote speech?
Well, so the big message is that telemedicine is nothing that's on the fringes anymore. It's mainstream, and it's growing, and it's part of the solution to this nation's healthcare dilemma that it's in right now. Shortages of physicians and caregivers. And it's not just about rural communities. So many times people think of telemedicine as the urban place reaching out to the rural place.
Yes.
But it's so much more than that. I'll tell a story today about telesepsis and what we're doing, even inside our biggest facility in an urban setting, using virtual care that's having an incredible impact on people's lives.
All right. Well, thank you very much.
You're welcome.